أهلا بيكم. In this lecture, we will continue talking about the thoracic walls, and this time it's the diaphragm, the inferior boundary of the thoracic cavity. So let's start. The diaphragm is a fibrous sheet that plugs the outlet of the thoracic cavity and separates the thoracic cavity from the abdominal cavity. It has two domes called each one is called cupola, copulae or cupulae, right and left. And you look for these if you suspect in chest x-rays. When you suspect emphysema, they will be lowered down or depressed down. When you talk about the attachments of the esophagus, the anterior attachments are higher than the posterior attachments. These are at level of T8, and the lowest attachment is at the level of T12, even between T12 and L1. And you can divide the origin of the diaphragm into three parts. There is a costal origin, there is a vertebral origin, and sternal origin. They all meet in the middle in a central tendon. The costal part is arising from the internal surfaces of the lower six costal cartilages, and when we study the abdominal wall, we will find out that there is a muscle called the transversus abdominis muscle arising from the same origin, so it interdigitates with the transversus abdominis muscle. This is about the costal origin. The lumbar origin is from the lumbar vertebrae or lumbar region, let's say, because it arises also from the lateral side of the lumbar vertebrae. Look at these ligaments, condensations of connective tissue. See that? This is the lateral arcuate ligament. This is the medial arcuate ligament. And this is the median arcuate ligament. Now, the lateral arcuate ligament extends from the midpoint of the inferior surface of rib number 12 to the transverse process of L1, this ligament. See, it partially covers the quadratus lumborum muscle. We will study this in the posterior abdominal wall. This muscle attaches to the iliac crest and the fifth lumbar vertebrae ligament, called the iliolumbar ligament, and stretches up to the lower surface of rib 12. It's covered by, or crossed by actually, the lateral arcuate ligament. Now, what passes, you will be asked, what passes under this ligament? It's the subcostal nerve and vessels. Subcostal nerve and vessels, they pass under this ligament. The other ligament, called the medial arcuate ligament, this time it's over the upper part of the psoas major muscle, and below it, the psoas major extends to the thoracic cavity. It extends from the crus to the transverse process of L1 vertebra. The crus, I mean the crus of the diaphragm, this tendinous origin. These are the cruri of the diaphragm, the right and left cruri of the diaphragm. So what passes under the medial arcuate ligament? The sympathetic chains coming from the thoracic cavity to the lumbar, to the abdominal cavity, passing under this ligament. So remember, the subcostal nerve and vessels under the lateral arcuate ligament, and the sympathetic chain under the medial, with an L, arcuate ligament. Now, the vertebral origin proper, by two tendons. The right one extends down to the level of L3, and the left one, usually shorter, to level of L2, and they blend with the anterior longitudinal ligament we talked about, that covers the anterior surface of the bodies of vertebrae up to the neck. We mentioned that before. So they fuse with this ligament and unite in the middle See, middle arch, this is the median with an N arcuate ligament. Actually, what passes under this median arcuate ligament, it's the aorta and the esophagus and the thoracic duct, and sometimes the hemiesophagus. The esophagus and hemiesophagus, sometimes they pierce the cruri. They don't pass through the foramen, but for sure the thoracic duct and the abdominal aorta, thoracic becoming abdominal aorta, pass under this opening. Now, if you observe the structure of this opening, actually the aorta and the thoracic duct are not do not go through the diaphragm. They are behind the diaphragm. See, because it arches over them, and they are not affected by the mobility of the diaphragm, descends or ascends. It doesn't affect the structures lying behind it. See, remember this. Now this opening is at a level of T12, and we will talk about the openings now. Remember that the right crus is bigger and arising from the anterolateral surface of upper three lumbar vertebrae, so longer origin. Also, what's unique about the right crus, it sends an extension of muscle. See that? This loop of muscle that surrounds the esophageal opening. See, this is the esophageal opening, and this is the esophagus passing to the abdomen. It sends a muscular sling around the opening to act like a valve-like action. And when you study the abdomen, you will know also that the right crus gives a share in what's so-called the ligament of Treitz, that has two parts, upper and lower parts. This is the upper part, extension from the right crus. It keeps the duodenojejunal flexure high up in place. So remember, the unique crus is the right crus. It's longer. It sends extensions around the esophageal opening, and shares in the formation of ligament of Treitz. We will study this with the small intestine when we study the duodenum, actually, in the abdomen. Okay, and the opening is between T12 and L1. So this is the actually the lumbar origin, the arcuate ligaments, the three of them, and the cruri. Now you go to the lateral side. It arises from the costal margin, as we said, interdigitating with the transversus abdominis, and then from the xiphoid process. This is about the attachment. Now this is a superior view of the diaphragm in situ. See, this is the right cupula, and this is the left cupula. This is the right and left cupula. It inserts the muscle fibers coming from different directions. See, inserts in a central tendon. It has three leaflets, anterior and two posterior. The two posterior extend posterolaterally, and the left leaflet usually thinner, slightly thinner than the right leaflet. See, all this is the right leaflet with the inferior vena cava passing through it. Now, what's important about this central tendon, that it's attached to the pericardium above. Here in this specimen, the pericardium has been removed, but in this one, the pericardium and pleura are intact. See the pleura covering the cupola, the right and left, and this middle portion, this sac actually is the pericardial sac with the heart removed. See how it's attached to the central tendon. You might wonder, what's the significance of this? Yes, with every breath we take, when the diaphragm descends, it pulls the heart with it. And when it pulls the heart with it, it pulls the inferior vena cava opening with it, lower down, so assisting in filling the inferior, the heart, the right atrium from the inferior vena cava. So it has a great significance. The filling rate, the cardiac filling increases with inspiration, and this you can observe on yourself when you breathe normally and palpate your pulse. You will notice a change in pulse with inspiration because of the increased filling of the heart. So it mechanically, this attachment mechanically assists the heart in its filling process, filling of the right chamber, the right atrium. Okay. Now another question. It might sound weird, but think about the contraction of the diaphragm. What happens in the diaphragm when contracting? Ascends or descends? Yes, some people think, yeah, but trust me, some people think that it ascends. It descends, actually. It goes down, descends, okay, pushing the abdominal viscera and increasing the intra-abdominal pressure. Also aids in pushing the blood to the right side of the heart. So this is about the insertion of the trifoliate structure of the central tendon of the diaphragm. It's easy. Now the relations of the diaphragm even easier. Superior relations, it's related of course to the thoracic cavity and pericardium. So actually it's related to three serous membranes, the pleura, one on the left and one on the side, and the pericardium in the middle. So you will not forget it. To three serous membranes, the pericardium and two pleurae. Inferiorly, it's related to liver and kidney behind it on the right side, see? And because the liver is big, it pushes the right cupula upwards. It may even reach the level of the fourth intercostal space. That's why the right cupula is higher than the left one. See that? This one is higher than this because of the size of the liver. So inferior and to the right, we have the liver and kidney with the subdiaphragmatic space, of course, in between. Part of it between the diaphragm and the liver, and part of it between the diaphragm and the kidney backwards. On the left side, we have also the left lobe of liver reaches the left, actually fifth intercostal space. With the fundus of the stomach, see, this is the stomach, this is the fundus of the stomach, and the spleen. Now, don't think that this is the normal, this is actually not the normal size of the spleen. It's too big here. It's usually smaller than this, nothing more than the palm of your hand without the fingers, okay? So, it's related to the fundus of the stomach, to the spleen, and to the left lobe of liver, and to the left kidney and suprarenal gland on top of it. Okay, the same case on the right side, to the suprarenal gland and on top of it. Okay, sometimes, by the way, the suprarenals find a gap in the attachment of the diaphragm. It happens, and the suprarenal extends through the thoracic cavity. It's part of the thoracic cavity. Don't be surprised. This is normal finding. Okay, the undersurface of the diaphragm is lined by peritoneum, and the upper part is related to the three serous membranes. So actually it's sandwiched between these membranes, the peritoneum lining from the lower surface, and the upper surface you have the pleurae and the pericardium. Okay, the apertures in the esophagus, actually numerous apertures, but there are three major openings. You should know them exactly well. Now, the first opening is the aortic opening. It's behind the median arcuate ligament. It's at the level of T12 and L1, and it's actually behind the diaphragm, and the two cruri meet in front to form the ligament, which is the boundary of this opening. What passes through the opening? The aorta, the thoracic duct, the azygos and hemiazygos veins, the thoracic duct between the aorta to the left and azygos to the right. This is if the azygos pass through the aortic opening. Actually, this is also the lowest and most posterior opening. You will be asked about this. Which one is higher? Which one is lower? Which one is anterior? Which one is posterior? This is the lowest opening and the most posterior opening. As you can see here, this is the aortic opening, this is the esophageal opening, and this is the inferior vena cava opening. Forget about this. This is one of the hepatic veins. This is the inferior vena cava. See how it goes up, and this is the boundary of the opening of the inferior vena cava. The next opening, the esophageal opening. See, this is the esophagus cut here, okay, passing through its foramen, and it's at the level of T10. Okay, and it's the middle one, neither anterior, neither posterior. It's in the middle, okay? And it's a little higher than the aortic. This is at T12, this is at T10. Remember this. Actually, this is a site of constriction of the esophagus too, because of the extension by the right crust we talked about earlier. So what passes through the esophageal opening? The esophagus, and there is a plexus of nerves around it called the esophageal plexus that gives rise to the vagal trunks and their branches. Gastric nerves, they pass through here too. And what else? Well, the inferior branches of the inferior gastric artery passes through the this opening. The left, I mean left gastric artery passing through this opening, and this is actually will be considered because of the venous drainage. This is one of the points where portosystemic anastomosis happens. Of course, you are familiar with the esophageal varices. Esophageal varices because of the portosystemic anastomosis. We will talk about it in details in the abdomen. So it's the esophagus with the nerves on top and below, the anterior and posterior vagal trunks, and their branches, the gastric branches, and the branches of the left gastric vessels. Okay. The third opening, it's the most anterior, it's the highest one, it's the inferior vena cava opening, this one. See? Inferior vena cava opening. It's a level of T8. And it's the most anterior, and passing through it is the inferior vena cava and the right phrenic nerve. Inferior vena cava and the right phrenic nerve. Now I want to talk about 2 points here. First of all, note that the inferior vena cava opening is in the tendon, inside the tendon. And actually the tendon fuses with the walls of the inferior vena cava. It's not separate. No, it's attached to the walls of the inferior vena cava. See the genius design here, because with every breath, the central tendon will be stretched because of the muscles pulling on it, right? While descending. So it will keep the inferior vena cava opened and aids or assists in the flow of blood from the inferior vena cava to the right atrium. See, this is genius design. That's why the inferior vena cava opening is in the central tendon while the other openings are not. The esophageal opening not in the central tendon, and the aortic opening actually is behind behind the diaphragm. I'm sorry, behind the diaphragm. Okay, there's and the other point is there's fascia around the esophagus that keeps the esophagus protected from the surrounding diaphragm and allowing flexibility but preventing upward displacement of the esophagus. Now another thing, lymphatics pass through each opening. Okay, lymphatics pass through each opening. Why am I telling you this? Because sometimes if you're suspecting hepatoma, for example, a liver tumor, you ask for chest x-ray. Why? To look for metastasis. Yes, metastasis, the malignant tumors, they send metastasis, cells, malignant cells through lymphatics or through blood, other than the direct invasion of the tumor itself to the surroundings, but it sends metastasis. So if you are dealing with a tumor in the liver, for example, you should investigate the lymph nodes or lymphatics in the thoracic cavity because of the lymphatics passing through the gaps. And please, you always keep this in mind. This is crucial in your assessment and treatment for such patient. Okay, so we have these three major openings. Other openings, yes. Well, the lower intercostals going to the abdomen, they pierce the diaphragm. Okay, lower 6 intercostals and subcostal nerve. These are openings. Other openings, yes, there are nerves called from the sympathetic chain called the greater and lesser and least splanchnic nerves. Sympathetic nerves going to the abdomen, to the celiac ganglion, to the aortico-renal ganglia or the renal plexus. They pass through the diaphragm, through the crury of the diaphragm. Okay, what else? We have the azygos and hemiazygos. If they didn't pass through the aortic opening, they will pass through the crury of the diaphragm. And these are considered openings too. Yes, and you can think about another opening, anterior, which is for the superior epigastric vessels, right? They pass through the xiphoid attachment of the diaphragm on their way to the rectus sheath of the abdomen. So it's not only the three major openings, you have multiple openings in the diaphragm. Okay? These are the apertures of the diaphragm. Now, what else? Yes, a hint about what's called the hiatus hernia. It manifests when when the esophagus is taken up to the thoracic cavity, or the fundus of stomach taken up to the thoracic cavity. It manifests itself by heartburn, severe heartburn, by lying down or when eating, and so. And when you investigate and do a chest x-ray, you will find bubbles, air bubbles in the fundus actually present in the thoracic cavity. This is a type of hernia, type 2 hernia, paraesophageal hernia, where the cardia of the stomach remains almost in place, but the fundus of stomach is taken up through the esophagus. There's another type of hernia where the cardia of the stomach actually and the esophagus are taken up and the fundus of the stomach is still under the diaphragm. These are the different types of what's so-called the hiatus hernia. Hiatus hernia, it's common in obese patients. Okay, because the fat loosens the tissues, loosens the muscle fibers, so it becomes weak. Okay, that's all to say about the apertures and the hernia that occurs. Okay, the supply for the esophagus is easy. From the intercostals, actually supply the periphery of the esophagus, intercostal vessels, and in the middle branches from the aorta superior to the diaphragm. Did I say esophagus? I'm sorry, diaphragm. Superior to the diaphragm and inferior to the diaphragm. See, These are the inferior phrenic vessels. See those? Inferior phrenic vessels supplying the diaphragm, central diaphragm from beneath. And there's a couple of these vessels at the top too in the thoracic cavity from the aorta, directly from the aorta. And the venous drainage follows the arteries to brachiocephalic veins, azygous and hemiazygous veins. It's like, you know, like usual, the veins follow the arteries. The nerve supplying, of course, the motor supply is by the phrenic nerve. The right phrenic nerve passing through the vena cava opening, and the left phrenic nerve piercing the diaphragm, but both of them actually supply the diaphragm from the undersurface. Every nerve divides into anterior branch, lateral branch, posterior branch to cover the muscle of the diaphragm. Sensory from the intercostals that pierce the diaphragm, actually at the periphery. Okay, so now you know the significance or the importance of the phrenic nerve in the neck, because if it's first of all, it was well protected in the neck by the fascia of the scalene anterior. Remember, we said that it's buried under the fascia of the scalene anterior. You must dissect the fascia to bring the phrenic nerve, and if it's cut or injured in the neck or along its course, the devastating consequence actually paralysis of the part of the diaphragm supplied by this nerve. Okay, so impedance of respiration. Okay. Okay, I have a question in mind here. It's a good question. First of all, the diaphragm, is it a voluntary muscle or involuntary muscle? I mean skeletal or smooth muscle? Well, it's skeletal muscle. The proof, well, the histological structure, of course, and it is supplied by a somatic nerve, the phrenic nerve, C3, 4, and 5. Okay, the other question pops in mind. If it's a voluntary muscle and skeletal muscle, why can't you hold your breath forever? I mean, the diaphragm must contract without your will. Actually, it puts you aside and start breathing by itself. Why is that? Is it because the diaphragm is involuntary or what? It has nothing to do with the diaphragm. It deals with the levels of carbon dioxide in blood. There are special receptors in the CNS that detect, remember the carotid body, for example, that detect the levels of CO2 and O2, and actually the CO2 because it's the poison gas in the blood. And if the CNS found out that you are actually playing with fire and holding your breath, it puts you aside, relieves you from control, and it takes the upper hand in breathing. And this is exactly what happens in drowning. People drown because they have to take a breath. They cannot hold their breath forever. So this is a tricky question about the diaphragm, whether or not it's a voluntary or involuntary muscle. Okay, well, that's it for the diaphragm, and next time we'll go to the thoracic viscera, the pleura, and lungs. I hope you got the maximum benefit from this lecture, and I wish you all the best. Thank you very much for watching.